Which antipsychotic is most likely to increase prolactin? Which one causes the greatest weight gain? And when a patient develops abnormal movements, how do you decide whether it is acute dystonia, akathisia, parkinsonism, or tardive dyskinesia? In this video, I will organize the important antipsychotic side effects into a simple framework and highlight the associations commonly tested in MRCPsych Paper A. Hello everyone, welcome to Crack Your MRC Psych. When revising antipsychotic side effects, avoid memorizing a disconnected list of every drug. Instead, divide the adverse effects into 6 broad groups: extrapyramidal side effects, metabolic effects, endocrine and sexual effects, cardiovascular effects, anticholinergic and sedative effects, and serious drug-specific complications. Now let us work through them systematically. To begin with, extrapyramidal side effects. Extrapyramidal side effects are caused mainly by dopamine D2 receptor blockade in the nigrostriatal pathway. The 4 major syndromes are acute dystonia, akathisia, drug-induced parkinsonism, and tardive dyskinesia. The easiest way to differentiate them is by their clinical presentation and typical time of onset. Acute dystonia usually develops within hours or days of starting an antipsychotic or increasing its dose. The patient may develop torticollis, jaw spasm, oculogyric crisis, or rarely even laryngeal dystonia. Risk is higher in young men and with high potency first generation antipsychotics, and this requires urgent treatment with an anticholinergic medication such as procyclidine. Akathisia usually develops within days to weeks. The patient experiences inner intense restlessness and may pace repeatedly, cross and uncross their legs, or say that they cannot sit still. Do not automatically interpret this as agitation caused by psychosis. Akathisia can be profoundly distressing and may be associated with suicidal thoughts as well. And management includes reviewing and reducing the antipsychotic where appropriate. Propranolol is commonly used for akathisia, depending on the patient's clinical circumstances. Now, drug-induced Parkinsonism generally appears over days to weeks, and the features of this include rigidity, bradykinesia, a shuffling gait, masked facial expression, and sometimes tremors. Management may involve dose reduction, switching to an antipsychotic with a lower risk of extrapyramidal effects, or cautiously using an anticholinergic agent. Tardive dyskinesia is usually a late complication, developing after months or years. It commonly causes repetitive involuntary movements of the mouth, tongue, and face, although the trunk and limbs may also be affected in some. Unlike the earlier extrapyramidal syndromes, anticholinergic medications may actually worsen tardive dyskinesia. So remember the approximate sequence: dystonia first, then akathisia and Parkinsonism, and then tardive dyskinesia much later. High potency first generation antipsychotics such as haloperidol, flufenazine are particularly associated with extrapyramidal side effects. And second generation drugs like risperidone can produce significant extrapyramidal effects, especially at higher doses. Clozapine and quetiapine have relatively low risks of extrapyramidal symptoms. The second common type of side effects are metabolic side effects. The major metabolic effects that you should be aware of are weight gain, dyslipidemia, insulin resistance, and type 2 diabetes. Clozapine and olanzapine have particularly high metabolic risks. Quetiapine also causes clinically important metabolic adverse effects. Aripiprazole, lurazidone, and ziprasidone are generally considered to have lower metabolic risks, although no antipsychotic is completely risk-free. A useful exam association is olanzapine equals prominent weight gain and metabolic disturbance. Patients require appropriate physical health monitoring, including weight or BMI, waist circumference, blood pressure, glucose or HbA1c, and lipid profile. The third is prolactin and sexual side effects. Dopamine normally inhibits prolactin release through the tuberoinfundibular pathway. So blocking dopamine D2 receptors can therefore increase the prolactin. And the clinical consequences of an increased prolactin would be galactorrhea, amenorrhea, sexual dysfunction, infertility, gynecomastia, reduced bone density with prolonged elevation of prolactin. Now, risperidone, paliperidone, amisulpride. These are strongly associated with hyperprolactinemia. Aripiprazole is usually prolactin sparing because it has got partial dopamine agonist action. It may sometimes be used to even reduce the antipsychotic induced prolactin elevation, but under specialist supervision. So for examination, the association to remember is risperidone, paliperidone, and amisulpride increase prolactin, whereas aripiprazole tends to reduce it. Now, cardiovascular effects are also something which can be associated with antipsychotic drugs. Antipsychotics may cause postural hypotension through alpha-1 adrenergic blockade. And this is particularly important in older adults because it increases the risk of dizziness, syncope, and falls. Antipsychotics can also prolong the QT interval and increase the risk of ventricular arrhythmias. So some drugs including ziprasidone and haloperidol, they particularly the intravenous haloperidol require very careful consideration of QT risk. Always consider other QT prolonging medicines, electrolyte abnormalities, and underlying cardiac disease when you are prescribing antipsychotics. Clozapine has an important association with myocarditis, particularly early in treatment, and with cardiomyopathy. And the warning symptoms of clozapine-related myocarditis would be chest pain, persistent tachycardia, breathlessness, fever, and unexplained fatigue. Anticholinergic adverse effects with antipsychotics would be dry mouth, blurred vision, constipation, urinary retention, and cognitive impairment. These effects are particularly important in older adults and in people with dementia. Clozapine has strong anticholinergic effects, but can also cause hypersalivation, which candidates sometimes find confusing. Sedation is prominent with drugs such as clozapine, olanzapine, quetiapine, and chlorpromazine. Now let us finish with the highest yield individual drug associations. With clozapine, try to remember granulocytosis or severe neutropenia, myocarditis and cardiomyopathy, seizures, especially with high doses or plasma levels, severe constipation and gastrointestinal hypomotility, hypersalivation, metabolic syndrome, and sedation. And this is why clozapine requires regular blood monitoring and careful physical health surveillance. Olanzapine can cause significant weight gain, diabetes and dyslipidemia, and sedation. Risperidone and paliperidone are associated with hyperprolactinemia, extrapyramidal effects, particularly when their doses are high. Aripiprazole is associated with akathisia, nausea or activation, relatively low prolactin and metabolic effects for aripiprazole. Quetiapine can cause sedation, postural hypotension, metabolic effects, relatively low extrapyramidal side effects. Chlorpromazine is associated with sedation, postural hypotension, anticholinergic effects, and photosensitivity. Remember, photosensitivity with chlorpromazine. Haloperidol is associated with extrapyramidal effects. It is a high potency antipsychotic, QT prolongation, especially remember the IV haloperidol, and neuroleptic malignant syndrome. Now, neuroleptic malignant syndrome is a rare but potentially fatal reaction. The major features of NMS are hyperthermia, severe rigidity, altered mental state, autonomic instability, and elevated creatine kinase. The antipsychotic in NMS should be stopped, and the patient requires urgent medical assessment and supportive management. Now, do not confuse neuroleptic malignant syndrome with serotonin syndrome. NMS is more characteristically associated with severe lead pipe rigidity and slower onset, whereas serotonin syndrome commonly produces hyperreflexia and clonus. Let's summarize with some quick exam questions. So question number 1, a patient develops a painful neck spasm 2 days after starting haloperidol. What is the most likely diagnosis? So look at the onset. It is 2 days with painful neck spasm. So the answer would be acute dystonia. Now, question number 2. Which antipsychotic is strongly associated with hyperprolactinemia? So what did we learn? We learned that risperidone, paliperidone, and amisulpride would be appropriate high-yield answers for this sort of a question like hyperprolactinemia. Question 3. Which antipsychotics have the highest metabolic risk? It is clozapine and olanzapine. Which antipsychotic is particularly associated with granulocytosis and myocarditis? Clozapine. A patient cannot sit still after starting aripiprazole. What should you suspect? Aripiprazole is very commonly associated with akathisia. So now let's quickly revise. Remember, haloperidol causes extrapyramidal side effects. Risperidone, paliperidone, amisulpride cause prolactin elevation. Olanzapine causes metabolic effects. Aripiprazole causes akathisia but relatively low prolactin. Clozapine associated with granulocytosis, myocarditis, seizures, constipation, and metabolic complications. If you found this helpful, subscribe to Crack Your MRC Psych for weekly Paper A, Paper B, and CASC videos. Let me know in the comments which pharmacology topic you would like me to simplify next. Thank you and see you in the next video.